Hi, my name is Taz Kicklighter. I'm the Athletic Training Program Director at Lee University. I want to thank the Athletic Training Education Journal for giving me the opportunity to discuss our latest article, Exploration of Factors Perceived to Influence Diagnostic Reasoning Ability in Athletic Trainers and Athletic Training Students. You can find the article in the latest edition of the ATEJ. And I also want to thank my co-authors, Paul Geisler, Mary Barnum, Scott Heinrichs, and Melissa Martin for your contributions to this article. Currently, there are only a handful of articles discussing clinical reasoning in athletic training literature, and of those articles, there's only two that specifically focus on diagnostic reasoning, despite decades of research in other allied healthcare fields. Therefore, the purpose of our article was to survey athletic trainers and athletic training students to determine if their perceptions of their diagnostic reasoning ability mirrored that of what we see in other allied healthcare fields. In addition to this, we wanted to determine activities that may either enhance or hinder their diagnostic reasoning development. Our hope is that athletic trainers and athletic training educators can use this information to determine activities and utilize activities that will further enhance their diagnostic reasoning development. Before I present our results, it's important for you to have a basic understanding of diagnostic reasoning. Diagnostic reasoning is a subset of clinical reasoning where an individual uses interconnected cognitive processes of focused thinking, problem solving, and decision making when making a diagnostic decision. You can read our current article or the two articles listed below for more thorough understanding. But at its basic level, diagnostic reasoning can be thought of as a fluid interconnection of two reasoning processes. The novice clinician will most likely utilize an analytical process known as hypothetico-deductive reasoning, where they encounter a new case, collect as much data as they possibly can, trying to make connections between signs and symptoms, and eventually come up with a few possible diagnoses. It's a disorganized, slow process and doesn't lead to confident conclusions. However, it's necessary for beginning diagnosticians to develop their memory structure. On the other end of the spectrum is case pattern recognition, where an individual with more intentional and reflective experiences will utilize a non-analytical intuitive approach of differential diagnosis. This system requires a highly developed memory structure where a person seamlessly integrates key features found in the evaluation and reaches quick and confident diagnostic decisions, a lot of times with incomplete data. Interesting, the research has shown that a clinician with more expertise will actually have a level of flexibility in their thinking where they can utilize both processes when appropriate. For instance, when an experienced clinician discovers a novel case with unique features, they will actually refer back to hypothetico-deductive reasoning to gain more understanding of that clinical presentation. However, as they gain more understanding, they develop an organized memory structure on that case that will later turn into case pattern recognition when they encounter a similar process in the future. Article was a small part of a much larger study where over 100 athletic trainers and athletic training students took online the Diagnostic Thinking Inventory for athletic training. The DTI-AT is a validated inventory which actually measures flexibility in thinking and structure of memory to give a person a quantified score that relates to their diagnostic thinking ability. From that group, we randomly selected 11 athletic trainers and 12 athletic training students to participate in the interview to gain a little more understanding of their perceptions. Our hope is that by taking the inventory prior to the interviews, that the participants would actually have some context of diagnostic reasoning, which would better frame their answer. You can see all of our results in our article, but I just want to take a second and hit the highlights here. We are very excited to see that the results of our article very much so coincided with what's found in previous medical literature. Overall, we discovered athletic trainers utilize a more non-analytical approach to diagnosis, while students utilize a more analytical approach, which is expected and consistent with what we see. In addition to this, although we haven't published the results yet, our participants' answers also coincided with their DTI-AT scores, adding validity to these results and the DTI-AT. In both groups, the most important factor perceived to enhance their diagnostic reasoning was professional socialization. Our theory is that this interaction with peers, mentors, preceptors, or instructors provides individuals with multiple perspectives for thinking, possibly leading to an increased structure of memory through continual feedback, script development, and better cognitive organization. Research has shown that this metacognitive practice is one of the most important facets for enhancing diagnostic reasoning. Interestingly, this was explicitly stated by our student population. As expected, on the other side, a lack of professional socialization or perceived negative preceptor and instructor interaction with students were considered the largest barriers to diagnostic reasoning development. An interesting result that we found in both populations was that they indicated a lack of time was a large barrier because it forced them to rush through a diagnosis and limits their time to research and reflect on their diagnosis. Interestingly, this result is actually counterintuitive because expert-level diagnostic reasoning ability ultimately requires less time to more accurately diagnose an injury or illness. So it should spur on an individual to develop more advanced clinical reasoning. The results, how can you use it in your personal professional practice or when educating students to enhance their clinical reasoning abilities? The most important thing to remember is that experience alone will not enhance clinical reasoning ability or diagnostic reasoning ability. The experience has to be intentional and it has to be reflective. In fact, a negative experience can actually hamper diagnostic reasoning ability. Clinical and educational experiences must contain a structured and intentional metacognitive activities, debriefing, questioning, something to force the clinician or the student to develop a more structured memory by making connections between signs and symptoms, developing illness and injury scripts, learning from their cognitive and their clinical mistakes. So I'm attaching here a list of articles which can help you with some clinical and some didactic techniques to enhance diagnostic reasoning. In addition to that, we also need to see if research from other allied healthcare fields can actually be applied to athletic training practice to develop diagnostic reasoning, but also therapeutic reasoning, all aspects of clinical reasoning. Finally, if you're interested at all in utilizing the DTI-AT in your program to track your students' practice or just for your personal development, please contact me at the email address below and I would be more than happy to help you out. Thank you so much for your time, and I hope you've enjoyed this presentation of our research.